My name is Saul Schaefer. I'm Chief of Cardiology at the VA Northern California Healthcare System and Professor of Medicine at the University of California, Davis. My talk today is on the role of high-sensitivity cardiac troponin in the diagnosis of myocardial disease. First of all, we need to define troponins as proteins, part of the contractile apparatus, and typically we use a cardiac troponin I and cardiac troponin T in order to diagnose damage to the myocardium. These proteins are released in times of injury, and the definition for a normal troponin is in the 99th percentile of the population. There are multiple causes for the release of troponin. Obviously, the primary cause in patients with cardiovascular disease is myocardial ischemia, where the cells die and troponin is released typically with early onset at 6 to 8 hours using normal detection levels. And there are other causes of the release of troponins. These are primarily in issues of altered cardiac supply and demand, supply going down into cases of hypoxemia or hypotension or anemia, and demand in cases of altered pathophysiologic states such as severe hypertension or sepsis. There's also a release of troponins with cardiotoxins such as methamphetamine, cocaine, and even alcohol over long term can cause the release of troponins. In non-cardiac diseases, troponins are released. That includes sepsis and patients with heart failure or end-stage renal disease. We actually looked at the meaning of low-dose troponinemia, which was defined as a troponin above the 99th percentile but below 2, and we examined 140 patients in our institution that were referred for cardiac catheterization with a low level of troponin but without clinical evidence of acute coronary syndrome. In our population, 11% of those patients had coronary disease, or looking at it another way, 89% of patients did not have any significant coronary disease despite an elevation of troponin. One would think that an elevation of troponin in the setting of myocardial disease has adverse prognostic information, and it does. However, in patients without coronary disease but clinically significant elevation of troponin, their mortality is actually 2.5-fold higher than in patients with a cardiac ischemic etiology for troponin release. And then finally, coming up are the high sensitivity troponin assays, a modification of the standard assay. These are about 5 to 10-fold more sensitive for troponin release than current assays. And there was an interesting paper in 2014 looking at almost 7,000 patients with chest pain, finding that a very low level, undetectable level of high sensitivity troponin had a negative predictive value of over 99%. So in other words, the absence of any elevation using this high sensitivity assay effectively rules out myocardial ischemia in a patient presenting with chest pain. So this has not yet been adopted in the United States, but we can expect its use in the near future, both giving positive value in ruling out myocardial ischemia, but also potentially false positive indications in patients without coronary disease. I think there are many benefits to the Congress. One is I get to see others, my peers, that are doing cutting-edge research over a wide breadth of fields in cardiology, from preventive cardiology to interventional cardiology, basic science. It's in an atmosphere where there's a lot of meeting space, where you can talk to people in informal settings, and the breadth in terms of its international flavor allows me to meet people from all over the world that are doing great work. And I think for the younger people that are here, it provides a venue for them to meet people that are leaders in the field of cardiology, get to know their research and get to know them, and also present their own work either in a oral session or in a poster session.